Thank you. Welcome everyone to our Primary Care Commissioning Committee meeting. I wanted to say of the summer time, but I'm not too sure if it's summer yet. But anyway, so yeah, thanks everyone for coming. Do we have any apologies for absence?
The only apologies that I had were from Ed Garrett, Paul Jabara, Steve Chicken and Andy Yaku, but Sue is here instead of him.
Thank you, Joe. We'll note those for the minutes. Second item, declarations of interest, hospitality and gifts. Any specific ones? Looking at you, Mark.
Yes, thanks, Manuel. My specific one is around my contract as a salary GP for Suffolk Primary Care.
Thank you. Yeah, we'll note that. Moving on swiftly, we'll have a look at the minutes of the previous meeting. The last meeting was held on the 23rd of February. As you remember, it was a shorter meeting because of everything that was going on at the time. But we'll just, check for correctness. Any comments, any errors on the minutes? No, I don't see anything. So thank you. We'll approve those minutes and we'll move swiftly to the action log from the last meeting. So looking through that, I think some of the items are going to be covered on the agenda. So I think we won't go into details around that. Things like health checks, I think Maddie will touch on those on the agenda. There's a specific one which I mentioned at the start of the meeting, which was on the annual plan of works, which said consideration to be given to undertake a patient survey to understand the impact of the new telephone triage systems and any other changes that have occurred as a result of COVID-19. And that was Andy Yakub. But I checked with Andy and apparently he wasn't. He didn't know that they were supposed to do some work. But I also know that there is some surveys that are being done by HealthWatch. And I don't know whether there is a link to that or it's something completely separate. I don't know, Sue, would you like to comment on some of the work that you're currently doing at the moment?
Yes. Just give me 2 seconds. So just generally, is it Manuel, the types of surveys that we're doing?
Yes, I mean, I just wanted to see if there's a link to, this specific work that was mentioned in the action log.
Okay. Sorry. Yeah, I mean, we obviously are still continuing to gain feedback reference to the COVID vaccinations. That is still an ongoing looking for positives and negatives and overall feedback generally of the vaccination process. That is still continuing to ongo. There are other research surveys that we are doing, but could you come back to me in just a few moments, Manuel? Will I just get that list up? Sorry.
No, that's fine. I mean, we don't really need to know everything. I'll probably just ask the committee that do we need to request HealthWatch to do a specific piece of work on the impact of the new telephone triage system. Mark, do you want to come in, please?
I think it would be very helpful to have patient experience as part of the progress, because telephone, I'm reluctant to call it triage, I'd call it telephone consultation, is going to be an ongoing methodology, which can be very convenient for both patient and for practitioner if it's done in the right way. So understanding patient experience in that will help to improve the way in which practitioners and individual practitioners work with patients through telephone communication and others. You know, we'll call it remote consultation, not just necessarily telephone.
Thank you, Mark. Maybe Maddie and David, we could look at how we progress this, if we needed, whether we need to commission a specific service or there's something already out there that we could just bring into the next meeting.
That's fine. Yes, we'll do that. Thank you.
All right, thank you. Is there anything specific on the action log that anybody wants to highlight, which is not covered on the agenda? No. All right, okay. So we'll move on swiftly. Over to you, Maddie, for your update.
Thank you, Fenwell. So I'm just going to mention 4 points because I think there's a great deal in the meat of the agenda. So the first point is my favourite topic, although we do have Caroline here, who I think will be the mastermind expert on this one in due course. So vaccination. Really pleased to report that the vaccination programme continues very positively, with primary care playing an absolutely pivotal role in it. So each and every practice is involved in different ways. There are some practices which are delivering from their sites on behalf of others, and some that are supporting the delivery from larger sites, such as that in Woodbridge or Trinity Park or Debenham, for example. So over 200,000 people have been vaccinated in Ipswich and East Suffolk now, and over half of those have now received their second dose. So that's incredibly positive. And our focus now is on the second doses. As you will know, people between the age of 40 and 50 have now or are being over a number of days invited to come forward for their first, but the focus, the vast majority of our focus currently today is on second doses, which will give that even greater level of protection to individuals. So that continues very positively, and the numbers are really very important, but it's equally important that we focus on ensuring that each and every individual is invited to come forward, has the information that they need to make their decision about vaccination. So we have been doing a great deal of work in our communities with our partners to try and enable that access and that take up. So that's vaccination, and as I say, we have the absolute resident expert with us in the committee, who is Caroline. So thank you to Caroline for all that you've continued to do for this programme of work. The second item I just want to mention relates to business as usual. So our practices continue to provide services they have throughout the pandemic, and it is getting busier. I suspect as people are being vaccinated and are feeling able to come out more, they are making contact with their practice about their healthcare, and that's a good thing. And there are many ways, as we've just started discussing, which we're working to ensure that patients' needs are met. But the practices are continuing to do an excellent job with an increased amount of need. And they have been very ably supported by David and Claire and other colleagues within the team during that time. So the third point I just make is about transformation. So as we've discussed before, and we'll come back to, primary care is going through a massive period of transformation with the creation of primary care networks, and they've begun to really work both within their networks, but also as a group of clinical directors. And beyond that, there's the third kind of facet of that is with their integrated neighbourhood teams. So we've seen some really positive progress, I think, over the last period when it's been so very busy in all of those different layers and levels of transformation within primary care and how primary care works with the other services in their communities. And the fourth point, just to mention, is we're at a stage now of very detailed planning for the year ahead. And primary care, it's called restoration or recovery or renaissance, is the general term used for us returning all services fully. And primary care has obviously a vital role in that, and we are looking at specifically at primary care's next steps. But most importantly, it's about the relationship between primary care and the other providers in the system as we do that. So the relationship with our community colleagues and with our acute and mental health colleagues, as well as with our wider community. So we're very focused on primary care, but we're equally focused on the role of primary care and the relationship of primary care with the rest of our partners as we prepare those plans. So those were the 4 points that I wanted to mention. They're quite high level, and I know that a great deal of the detail will now be covered. But just to end again with a huge thank you to all of the practices for their continued, very intensive hard work, and for the team here that support them so well. Thank you.
Thank you, Maddie, for that update. I think I want to just comment on what you started with, which is sort of thanking the team, particularly Caroline, and the work that has been done around vaccination. For some of us, doing some work in the communities, there is quite a lot of appreciation. I think widespread appreciation is what I would call it. People who are getting calls to get their vaccinations, people who actually didn't even expect to get their vaccinations at the stages that they're getting them. And so in the main, I think there's been quite a lot of positivity, and I think it's thanks to the hard work that the team has put in. So I just wanted to add my appreciation to that and say thank you. We know that you have had to go outside of your sort of usual remit, but actually you've executed that exceptionally well. So yeah, thank you. Any specific questions or comments on Maddie's update? No? Okay, thank you. I think we'll move to the next item, which is Caroline, over to you for the contracts and performance report.
Thank you, Fanwell. Actually, just listening to Maddie's 4 points there that she started with, and I realised that mine are going to sound almost the same. So I'm going to make a last second dash to try and change it slightly, because I was going to start with, I think that the report is quite well described in each of the areas. I think it's quite a thorough report, and I think it goes to quite some lengths to describe each of the details. So I was going to take a bit of a canter through the report to enable you to get through the rest of the agenda, because I know that part 1 and part 2, you've got quite a lot of items on there, and some of them are for decision, whereas this, I think, is more for information at this stage. I think what the report does describe, if we look at SMI and LD in particular, as Maddie has said, it's showing that we are moving back to a really busy BAU. It shows that primary care is open for business and is seeing face-to-face patients, face-to-face appointments where it's absolutely appropriate to do so. And that's really encouraging if we look at our LD figures, for instance, these are the right people to be seen, and they are actually getting seen in primary care. So I think that demonstrates the level of returning to restoration and recovery that we have, but also obviously some of the figures are probably slightly more reflective of the current situation. For instance, the dementia diagnosis rates are still a little bit low. We know the reasons behind them, but there's still more we need to do to action those and get that back on the agenda, if you like, back out there in primary care. So there are some things that we need to do behind the scenes. And as Maddie touched on around the PCNs as well, I was just going to bring us on to that. So we know that the PCNs have had an instrumental role in the COVID vaccination rollout with the communities, and some of the integrated work with the INTs, which has been particularly important over recent several months. But it's also helped us accelerate some of the work of the PCNs as we're moving into the rest of this year. So we know that the PCNs are focusing on the cancer diagnosis, the referrals. We know that the additional roles reimbursement scheme will help to accelerate some of that work, along with the population health management. And we know that these are all areas for the PCNs to focus on. And because if we have had COVID, some of these have actually accelerated over the period, just naturally progressed, actually, which is a really good thing. But that's sort of the focus, I think, for PCNs going forward of some of those areas. And you'll see that in part 2 when we look at some of the papers there around the maturity of the PCNs and how they've really come along since their inception. And just to finally note is we've, for the first time, we've included the complaints data within this report as a recommendation from our auditors. So it is in here, it's probably quite high level, so I'm happy to take feedback about, you know, how useful that is to the committee, or whether we keep it or just for information going forward. So it was on recommendation of the auditors. I think it does show that actually complaints is not high in volume across our patch, which is also good. But I think we'll keep it in there, but just, you know, to take any notes as to how useful that is. I'm happy for any feedback on that.
Thank you, Caroline. I think maybe starting from there. I mean, I've had a look at the complaints, and actually, you know, given the situation that we've been in, you know, talking to communities, particularly, I mean, there's a piece of work that we're doing with elderly people in the community who are, you know, sort of slightly worried about, you know, access to, you know, GPs, access to health services, and the situation that we've gone through. So I actually feel that maybe we're doing very well, because under the circumstances, we probably would have had, you know, many more complaints than that. So I think it's something that we probably need to keep an eye on.
Yeah. I should probably note that these aren't all the complaints that come into general practice. Mark was probably just about to say that, his hands shot up. You know, most of the practice complaints go straight to the general practice themselves. These are the ones that are captured by NHS England. We also obviously have our PALS line at the CCG that deal with low-level queries. You know, I would say complaints perhaps is a different term, but you know that we do have sort of several mechanisms for these. So these are the NHS England complaints that we're reporting on in this report.
Thank you. Mark, and then Lorna.
Thank you. And I'll come back to the complaints thing as well. I mean, we reckon 6 contacts per patient per year on average for a general practice. So times that by 400,000 patients, you know, 2.5 million contacts. It's a relatively small, but they're all very important because there's learning that has to be taken away, and practices in the main, as Caroline says, do manage their own complaints in-house, as they're encouraged to do. It would be, and I'm sure that as PCNs develop, they'll work on their complaints as a means of looking at areas for improvement. And I know certainly within Suffolk Primary Care, where, you know, they're looking at about 12, 13 different practices across Suffolk, trying to work to one complaint methodology, so that as much as possible is captured, recorded, analysed, and then worked on in terms of what are the themes and what are the improvements we need to make. You know, I think it's a reflection of how important it is, but how uncommon it is as well for practices to get complaints.
Thank you, Mark. Lorna.
Yeah, no, I think it's a good idea to see them, even if they're high level. I mean, we report them in the trusts. We look at them. They're looking for general themes there. If, you know, if there's suddenly a change of direction and the public don't like it, you might pick up a theme there. I think that would be difficult on an individual practice basis. So I think that they should stay there. I also think that the patients have been very good this year. I think they've been pretty stoical and understanding of what has been going on. So, and I think that that has made a difference to a lot of people's work really over the last year. So I just thought that should be logged, really.
Thank you. Thank you, Lorna. The other thing which I also wanted to comment on, Caroline, you talked about, some of the good work that has been done, particularly in terms of engagement with communities. I know that, some of the work that has been done, with the bus and, sort of PCNs and the different practices, we've been able to reach out into communities that traditionally we wouldn't be, and we've, been able to work in ways that we don't usually do, but actually that has allowed us to actually, do much more than we would normally do. I suppose the slight kind of hesitation is around how do we learn from that way of working and actually ensure that, we won't continue to talk about, hard to reach communities or seldom reached communities, because during this time, as difficult as things have been, we have been able to reach those communities. So it's about how we utilize that learning, in order to then continue to do things. I know that, we've had to do things differently, but is there any way that we can actually bring some of those things and mainstream them and start doing things differently? Maddie?
Thank you, Fanuel. I think that's a really excellent challenge. And I think the question, and I've been thinking very much in terms of the vaccination programme, is what is our learning and what is the legacy of that? And so I think you're absolutely right, Chandra, on how we apply that across all of the services that we provide. And maybe that's a short report that we could bring back to the committee on learning and legacy in discussion with the practices, and I think maybe with Health Watch and colleagues too, and what can we learn for that in the restoration, the full kind of recovery restoration programs that we will be including in the plan. So yes, thank you. I think we should absolutely make sure that that's robustly considered as we move forward.
Thank you, Maddie. Yeah, I look forward to, seeing that at a future meeting. All right, we'll move on to item 7 on the agenda, which is the primary care delegated commissioning. Jane?
Okay, yes, thank you. So included in your pack is the finance report up to the end of February. We obviously have moved on since then, and we have closed the books for this full year, but all I can say on that is that it's reflective. The month 11 report is very reflective of where we ended up at the year end. So it's a similar picture to we've been reporting to the committee all the year. We have 3 main funding streams as a CCG. As a reminder, we have our running cost allocation, we have our main programme allocation, and we have a separate delegated budget for primary care, which is what we're reporting on here today and what this committee looks after. Unfortunately, the amount that we receive in that delegated primary care budgets is insufficient to fund the core delivery that we provide within primary care. So what you see in the table, see in the report are 2 tables. The first, which actually reports on the delegated primary care budget overall, where you can see that there is at month 11 and continue to the year end an overspend on that budget, or a spend that is higher than the funding given, if that's how you prefer to see it. That's offset by a primary care contingency that we set aside within our main commissioning budgets. And so you can see overall the 2 offset each other, so that we have provided sufficient to cover the costs within there. One of the things we were talking about this morning at the clinical scrutiny committee is about exactly how we present that, and trying to demonstrate within the report as we move into the new year that this is about an underfunding issue rather than an overspending within particular lines. So we will look at potentially tweaking the report next year to demonstrate that more clearly. But within the report itself, as I say, no particular changes either in month 11 or as we came towards month 12. You can see there's that the main area where the budget is insufficient is in that core contract. There's been a few other smaller changes, smaller overs and unders within the rest of the budget, but effectively it's a position that we were expecting to deliver. It was slightly different this year because the first half of the year we were all NHS bodies were topped up from central funds due to COVID. We were working on an emergency planning arrangement. So effectively what you're seeing is a kind of a half year impact. So as we move forward into the new financial year that we've just started, we will be moving back into a more normal situation, whereby we'll see that sort of continuation of the second half of the year for the full year, and that we will, as we're doing our budget setting at the moment, we need to make sure that we allow sufficient room within the overall budget to fund all of the work within primary care overall. So apologies, that's a little bit of a gamble through, but the headline for the minutes is month 11 on finances continuing as expected. For month 12, there was just a further month of that, and overall the CCG, when it's looking at its 3 budgets overall, has delivered very close to break even, a very small surplus of about 9,000 for the year, subject to audit.
Thank you, Jane, and thank you for your oversight on our finances and making sure that we're kept in line. I suppose for me, on the risks, we talk about the risk not reflected, which is further increases in rent reimbursement and additional practice management support. Is that something that we have to think about or worry about, given that we are in month 11?
So I think moving forward, and obviously we've got some papers coming up particularly in the part 2 meeting, around changes which will affect the rent reimbursements going forward. Anything that increases the spend obviously is pushing against an already overheated budget envelope, for want of a better way of putting it. So we do have to consider that, consider all of those overall, but what we're not doing is looking at the primary care budget just on its own. We are looking at the kind of primary care resources overall, but it does mean that every decision that we make to increase spend is effectively is a difficult one to make, because we already know that we are spending above the amount that we were originally given to us as a CCG. So, but we've got to see that in the context of what does each of those changes deliver, how does it impact on our delivery of services overall, and so it's quite a tricky one. It's much easier when you've got a nice budget with a bit of a nice reserve in there, and you can say yes, we'll allocate a little bit of that reserve towards that development. I think it just means that there's increased emphasis on us in terms of all those risks and changes, to look at them in detail and make sure that they deliver what they say they're going to deliver.
Thank you. Thanks, Jane. Mark?
As a CCG, we weren't given those budgets, in the way that we're given them now, and I would say that the failure to cover the historic cost of core local primary care and passing on that underpayment to the system is a really sorry state of affairs that I would personally regret. Particularly as this decision around what comes into our system has been made unilaterally, and I think it undermines the principle of delegated commissioning. We took on the delegated commissioning, and then we had our budget cut. That is how it is. And it's also compounded by the challenges of accessing the opportunities that the PCN DES offers nationally. And I would say that NHS England, in terms of primary care, are trying to have their cake and eat it from a financial perspective, whilst trying to make every pound count in primary care, of course. But I'm sorry, I cannot support the way that this has been done.
Thank you, Mark. Yeah, we will note that, and I think you also speak on behalf of the rest of the committee on that. So I don't see any hands. So the recommendation there is for us to note month 11 performance, and so that is duly noted. Thank you very much, Jane. So we move on to item 8 on our agenda, which is the Care Quality Commission, and it's Claire.
I'm going to do it, Manuel. Claire's on holiday for the week. Not that you'd know it. She keeps filling my inbox and appearing at various meetings that I attend, but she's officially on leave. So I'm going to present this paper. It's largely nil of note. The reason for that is as we know, CQC have suspended their inspection regime, except for those practices that are at the very bottom of the pile in terms of quality. Thankfully, we don't have any of those in Ipswich and East Suffolk. They did put in place a mechanism, I've forgotten what they called it now, emergency support framework to guide practices in terms of how to deliver things through the COVID infection period. But overall, the CQC position in relation to our practices remains a very rosy one, which is the first appendices on the paper. So I'm happy to take any questions if anybody's got any on this one.
Any questions? Yes, Maddie.
It's not so much a question, just an observation that in due course, I'm sure that inspections will restart, and we know that they have been being progressed in some of our acute trusts in specific departments on specific services. So I think we don't have any guidance yet. It'll be really important that we work with the CQC and with the practices to understand the new process within the new world, if you will, as we move forward, and to support them with the preparation for that. And I know that David and Claire will do that. And we've previously had some very successful events with the CQC and with the practices on those kind of briefings, in order that people are able to understand what will happen in that process. And we would certainly hope to do that again, albeit this time I suspect it will be on Teams, not in Trinity Park.
Indeed.
Thank you, Maddie. Yeah, I think it's and David, you and I had a chat about this, where I was saying, yes, we've gone through this period where maybe things have been done a little bit different, but I'm quite certain that there are internal mechanisms for checking quality and all that. So it's not sort of the fact that we're overly reliant on CQC, but it's just making sure that as and when we get back to these checks, that we are all prepared for them, and there won't be any sort of major surprises for any of the practices, particularly some that were audited as far back as in 2015, 16. So yeah. Just to note that.
Yeah, good point.
So the recommendation there is for the committee to note the CQC's findings and to consider any further actions for the CCG or NHS England at this stage. I don't think that there are any. So yeah, I think we'll just note the findings. Thank you. We'll move on to item 9 on the agenda, which is a report on the decision of the virtual meeting that was held on the 11th of December. The report is there, but I don't know, Maddie, did you want to comment on that, or just?
I don't think there's much more to say. Thank you. As you all know, because you were members of the committee that made the decision, which was to so the 11th of December, that was when we were really gearing up for the vaccination programme. And obviously there's many costs associated with the programme in terms of the preparation of sites, in terms of the administration and the management of the process itself, as well as obviously the clinical process. And so the funding that was requested was for just over £1 million, £1.057 million, to enable that programme to be delivered. So the committee met virtually and considered and approved that recommendation. David, do you want to add?
Yeah, if I may, one of the interesting things is, if you remember, if the members of the committee remember that far back, we actually part of that use of that money was to incentivise practices around completing the learning disability health checks. And I know when that was proposed, there were quite a few groans amongst practices going, it probably wouldn't happen and it wouldn't work. If you remember back to Caroline's paper a few papers ago, we had one of our best years with LD health checks. So just to flag back to the committee, the members of it who approved that paper, that There's some real positive benefits that we got out of that we can measure, as well as continuing to support primary care through what was a very tricky and difficult period, which we're still in, but certainly coming out of now.
Actually, David, that's really helpful. What's interesting with this, we are asking you to formally ratify the decision that was made in December, but we actually already have evidence of the outcome of that investment, whether it is in LD health checks or in supporting staffing and or in the delivery of the vaccination programme. So the evidence, the outcomes are already there of this investment, and again, that can come back in a more formal written way in due course if helpful. Thank
you both, and I think that is really important because it also informs how we make some of these decisions in future. It's evidence that this is something that was well thought out, and it has turned out as well, if not better than envisaged. So yeah, thank you for doing that. So I want to believe that the committee is happy to ratify that decision, which has already been made. Moving on to item number 10, over to you, Stuart, for the contractual update.
Yeah, thank you. Good afternoon, everybody. So this is just this is a standard report that NHS England is providing to all 3 CCGs across the patch at the moment, to each standard PCC meeting, just to give you a flavour or an update of all the sort of contractual issues, contractual changes that have been made to your general practices since you last met. I'll take the paper as read, just to clarify, obviously, because we cover the whole of the FTP, we have just done one paper to be presented at each of the 3 CCG separate PCC meetings, but in relation to yourselves in Ipswich and E, just to clarify in terms of the contractual updates that I have listed, the ones relating to your CCG are under list closures, the Barn Claydon practice, under mergers, the North West Ipswich merger, which is Norwich Road, Chesterfield Drive and Devon Road, and under super partnership, the Suffolk Primary Care. So that's the contractual changes. And then this time, because we've literally just passed the 1st of April, which was the go-live date for the latest GP national contract changes, I thought it would be helpful just to summarise what those changes are this year in relation to their impact on general practice. So that's the second part of the report. I don't propose to say anything more than that, but I'm obviously happy to take questions.
Thank you, Stuart. Yeah, I note that some of the things they will probably discuss further later on. Any questions from members of the committee? No. Just maybe for my own understanding, Stuart, this might seem quite mundane. You mentioned there that on the cervical screening, that this additional service will become an essential service. What does that actually mean in terms of?
Okay, so up until the end of March, in the GP contract, it separates between what we call essential services and additional services. So essential services are those services that a GP contractor has to provide if they have a contract with the CCG for primary medical services. Additional services are those that are part of the contract, but there is an opt-out facility, so practices can opt out of providing those additional services. In Suffolk, that's never been the case, as far as I'm aware. Most practices have always opted in by default to those services. So nationally, the decision was made that for cervical screening services, I think very much because of the impact of COVID and so on, the decision was made to make that an essential service. So basically, a practice can't opt out of that service; they have to provide it. What it means, the flip to expand on that, with additional services, what that means is that if a practice does opt out of providing that services, then it falls on the commissioner to commission that service from another provider. Okay.
Okay. No, that's fine. Thank you very much for that clarification. I suppose for me it was just trying to gauge whether there will be any significant impact. But I suppose from what you're saying that we have always been opting in, or the practices have been, so there won't be, sort of major. Okay.
Yeah.
And then there's the digital offer, which you mentioned that it's core. I suppose maybe just to hear from some of the practices, people like Mark and others. I think for me it's just more less from the kind of sort of commissioning perspective, but to say some of the issues that we've had from communities in terms of use of digital, where we've had issues around access, challenges around access, and people saying maybe that service isn't working for them as well as they some of the elderly people in the rural areas and other places not having the sort of technology. What does this mean in terms of, I suppose maybe we'll still be providing our usual services but also augmenting with that?
Yeah, I would say that that's the intention. So this isn't about being completely digital or completely face-to-face. It's a mixed economy, if you like, of methods of access to healthcare, the advice, etc. I think there's still quite a lot of work to do on how to do that effectively as a practice, and where it is just another way in, it can be quite challenging. Where you're, doing perhaps a traditional face-to-face set of appointments, then a set of telephone calls, then your email access, then your video consultations, and then back to face, and trying to juggle all of those at once, the multiple ways in which it appears that people can get access to you. I think trying to take a joined up approach about how does a practitioner within a practice manage that whole demand, perhaps in a different way, so that it's not multiple ways in, but one way in with multiple ways out, if you like. So you're managing the whole demand that's coming into the practice in a more operationally coherent way. And I certainly, looking from an outside, I can see that some practices will go, oh, I'm just giving up on a digital platform because it's just too much in addition to everything else that I'm doing in this chunked up time. And there are other practices saying, look, everything comes into one place, we can sort it out and then manage the access as a consequence. And I think that gives better control to the practice and hopefully better access for patients and a better approach overall. But I think it'll take a while, and I think it would take some specific training around that.
Okay, yeah, and yeah, no, thanks for that, Mark. I suppose there's also an issue around patient confidence as well in that sort of new way of working. So whilst it is an extra arsenal in our bag in terms of engaging with our patients, but I think there's an element of people are used to your doctor saying let me peer into your eyes, let me open your mouth, let me look at your skin, let me all those sort of things. And how much confidence do people have on this sort of new way of working, and how happy are they? And I suppose the question would be, how do we then deploy? Is this something that is optional for those who don't have the confidence to say, I want to come in and sit with my GP, or it's just offered as a...
And I think that comes down to the confidence of both, really. You know, the practitioner's approach to a consultation that is not face-to-face, where you can see all the non-verbal clues, as well as hear the verbal ones. So I think which is why I'm saying avoiding triage, where triage is saying this is the right place for you. That's not what this is. This is consultation. You know, telephone consultation is different to video consultation, which is different to face-to-face. There are nuances. There are different things that you need to pick up as a practitioner to get to the end point where you've got an agreed approach between you and the person who's wanting to have your advice. And I think that's the challenge with this. Have we had a mutually acceptable consultation? Has it delivered what we both hoped for? Now, that's normally what we do in just a face-to-face approach. That's what we're trained for. But the digital and the phone and the video have just opened nuances that need to, you know, we need to continue exploring.
So is there specific support that is given to practitioners, you know, particularly those who probably lack confidence in delivering this type of service?
There are consultation training programs. These are all still relatively new, and I'm not aware of anything that really provides a comprehensive approach to how do you manage all of that in one place. I remember we tried to engage with Red Whale, who are a very well respected GP training team around this, and I have to say they didn't have the answers back then either. In fact, they were working with us to find out what were the problems and how could we maybe get a training program that looked at all of these different aspects and bring them together. So I think there's still an opportunity out there if there's any provider wanting to take up that challenge.
Thank you, Mark. Sorry, Lorna, I know you've had your hand up for a while. Please do come in.
That's right, thanks, Manuel. I was just a comment, really. That obviously hospitals have moved quite far, pretty quickly with all these different forms of consultations, and it may be that the survey that we'd like Healthwatch and Andy to do, there might be quite a lot of information in secondary care about that sort of thing. Certainly they've probably got the complaint side there, but they've probably may also have done some proactive work to see what's working best for which groups of patients and how that can be accommodated. And I think that we will be facing some of the same things that in secondary care that you'll be facing in primary care. And I think it will be an evolution. I think as more people understand this is the option, the younger patients will embrace it because that's the way they like to be, really, and they will be helping older people, and then slowly it will evolve. But we do want it to evolve in the most efficient, safe way, don't we? So I think it's worth seeing whether secondary care has got any information there, already data they might already have collected. I don't know whether Andy wants to do that.
Yeah, thank you, Lorna. Yeah, I think we'll pick that up when we have the discussion around the survey. So thank you, everyone. So the report is noted, and thanks for the paper, Stuart. Moving on to item 11 again, Stuart, the policy.
Okay, yes, thank you. So, this report is to do with the Primary Medical Care Policy and Guidance Manual, which is basically NHS England's Bible in relation to all GP contractual matters. Some members of the committee might remember I did table a report probably 2 years ago on the PGM per se, just to sort of let you know it is. So it basically covers all aspects of contract management and monitoring. Every year it is refreshed, obviously to take account of all current legislation and guidance that is out there. So the current policy guidance manual was published in February. So it was just really to bring to your attention the changes that have been made to that manual. At the top of the report, there is a link through to the actual manual itself on the NHS England website. And if you look at that manual, you will see that all the highlighted changes in my report are highlighted in yellow on the actual manual itself. So it basically, the policy guidance manual is used by all staff within the NHS England primary care team to help CCGs manage their delegated primary care function. It's worth stressing, as I always do, that it is only a guidance, a guide. Obviously, when it comes to contractual matters themselves, it's always the regulations that trump the guidance. But normally we look at, both one in conjunction with the other. So the changes that I've listed are the changes that have been made to the manual in its last refresh. I don't propose to go through them all. I'll just take it as read, but obviously I'm very happy to take any questions or to expand on any area that members would like me to. Thank you.
Thank you, Stuart. Any comments on those changes? There is, as Stuart has said, there is quite a few in there. David?
Just an observation. The way might help the committee, I think of this policy manual as a bit like the highway code.
Yeah.
So the highway code actually pulls together lots of rules and laws that we're not that au fait with and codifies them in a relatively simple way of understanding it. For those of you who've ever read this policy manual, it's probably not quite as interesting as the highway code unless you're a bit like Stuart or myself. But if you do want to test the officers on this committee, just read a chapter and ask us a question. Well, make sure Stuart's there, of course. Yeah, I think of it as the highway code. It is a really useful way of pulling lots of regulation together in a relatively useful and interesting way. Interesting is a bit strong, but you get the idea.
Yeah, and of course, whenever we bring a paper to the committee about a merger or list closure, we would always quote the relevant section of the policy guidance manual, so you will have it in front of you in the cases. But I just thought in the round it would be useful, to show you what had changed.
Thank you both. Yeah, David will probably take you up on that offer. That's fine. I know, Maddie, you had your hand up and then you put it down.
No, it's fine. Thank you, Stuart, for preparing the paper. And so for reassurance, I do have a copy, and it is, I agree, it is useful and necessary for us to have it. But I always know that in you, Stuart, we have the fount of all knowledge on this. So yes, thank you. And David, obviously, as well.
Stuart's the expert.
It is a really important document. It is, and I'm pretty confident that what we are doing lives by this set of guidance. Thank you.
Thank you. So what is the recommendation there? Are we required to approve of those changes, or it's just for noting?
No, just a note. Just a note, please. Yeah.
All right. Thank you very much. Noted. So are there any questions, comments? Okay. I believe that we don't have any questions from the public, unless if any have been received during the course of this meeting. Joe, could you confirm that's the case?
No, I haven't received any.
Haven't received any. All right. Thank you very much. So if there's no further questions, I think we'll close this meeting. Our next meeting is going to be on the 22nd of June at 2 o'clock. If members of the